So this is going to be just our first lecture into oral board review for the year. Last lecture of the day, which is always rough, I know, so we're going to try to get through this first part a little quick, just some basic information, but we're going to be doing a case demonstration at the end of this. As a lot of residents know, Dr. Aquila used to do this part of the teaching for the residency, but she stepped down, so myself and Dr. Gernsheimer have taken over it. We're going to try to replicate a lot of what she's already done, but we're adding just a few new things this year for most of the oral board sessions. Today is going to be fairly standard intro, especially for residents who are unfamiliar with what the oral boards are, especially the junior residents, and a good refresher for some of the senior residents. Dr. Sharifali and Taitt are going to be helping us throughout the year set up the actual case sessions, especially. So today is going to be a lecture with a demo case. The rest of the sessions will be small groups, mostly with seniors, but also with the juniors this year as well, to get the juniors some exposure into what the oral boards are and how to start practicing early. So today I'm going to do a quick discussion about what the oral board exam actually entails. I'm going to give a brief example of how you can organize yourself during your practicing and on the board itself, and it's going to highlight some of the resources that Sharifali sent out to you guys. And then we're going to have the second half just a mock case demonstration here with Dr. G and Sharifali. So what is the eOral, the electronic oral board exam? So ultimately, it's the third and final step to obtaining your board certification. First step is completing residency. Second step, passing your written boards. And then you'll have the opportunity to do the oral boards. And upon completing and passing that, you become board certified. So why does ABEM actually do this in the first place? Well, it turns out that written exams, multiple choice exams, are not the best marker for determining if someone's going to be a great doctor, which is shocking, right? So they decided to add this aspect of board certification to test the skills that are probably more important and the skills that are not tested easily on written exams. So specifically, it's going to emphasize your ability to organize information, communicate to your patient and to members on your care team, and to make correct decisions based on each specific patient encounter at any moment. You're going to take it 1 year after passing the written exam. You can't take it before you pass it. Upon passing, you're guaranteed one seat at either the fall or the spring session. So it's only offered twice per year. And that's an important thing to understand. If they're only offering it twice per year, and if everyone who just passed their written boards is guaranteed a spot, that means that the majority of spots are guaranteed spots for physicians who just passed their written boards. This means that if you don't pass it on your first try, you're probably not going to get reassigned for another seat in the following session 6 months later. You're probably have to wait a year and maybe even up to 2 years. So you want to make it count. You want to practice this, you want to study it well, and you want to just pass on your first try. Otherwise, you'll be delayed getting your board certification. That can delay sometimes what your salary increase will be and a host of other things. Now, that's not to say you have to freak out about this. This test still has a fairly high first-time pass rate. I think it's still 95%. But that just means you need to prepare so you're a part of that 95% and don't blow it off, wait till the end and be a part of that 5%. So it's still currently held in Chicago. It's at one of the airport hotels. You'll be assigned a day, a block of time, and you'll get assigned to usually a floor on the hotel. Each of the hotel rooms will be a testing room with an examiner at a desk. You'll do your case. When you're done with your case, you leave the hotel room, you go back down into the hall, and when time starts again for the next session, you go to the next hotel room, and so on and so forth until you're done. So you'll have to plan this out in advance. I'm not going to go through all the specifics of dress code and confidentiality and all these things. That's all on ABEM on the website. You can always ask me, Dr. G, when time comes, if you have specific questions about it. What I really want to go into is what they're actually testing with the encounters and things that you should be looking for as you're studying. So let's talk about the cases themselves. On the actual day, you're going to be doing seven different encounters. 5 are single patient cases and 2 are triples. Single patient cases, very self-explanatory. You're going to walk into the room. They're going to give you information about one patient. You're going to manage this patient, work through the case, and upon ending the case, completing it, dispositioning the patient, you leave the room, and that was the entire encounter. So you're going to have 5 of those. 2 of them will be triples, where you'll walk into the room, they present you, patient A has come in for this reason, you manage the patient, and somewhere around your assessment and plan and initiating your diagnostics and your orders, they'll say, hey, patient B is here now, and you'll go and evaluate that patient. Same thing, you do your assessment plan, you put in your initial orders, and then patient C will arrive. And then at that point, you'll be bouncing back and forth between patient A, B, and C, completing all their dispositions, and once you complete the care of all 3 patients, then the encounter ends. So there's 2 of those. So since 2017, they have now moved these single cases to computer-based, and that's where the electronic oral board comes in. The triples will still be on paper. So they'll give you paper information, paper EKGs, paper x-rays, for example. And then there's no live video to interpret in those cases. When we do our sessions, we're going to be doing everything with paper, just logistically easier. But you'll have the ability to practice with the software. You can go on AVEM and take a look at how it is. And on the day of the test, you're actually able to go into a practice room hours before your test or whenever you want to sit and actually practice with the software if you want hands-on on the day. So you're going to do these 7 cases. Only 6 are going to count. The 2 triples will count, and 4 of the 5 single cases. One of the single cases will be an experimental case that AVEM collects data on to see if they're going to roll it out for scoring in future sessions. And you won't know which one is the experimental case. You'll just know that it's one of the single cases, which is good to keep in mind. If you're on test day and you had a really weird case, you think it didn't go well, maybe it didn't go well, or maybe it's just an experimental case that's going to get thrown out anyway, and you're not even getting scored on it. In total, you get 15 minutes per single case and 30 minutes per triple. And these cases are designed so that you have way more time than you need to complete them at an easy pace. And when I did my oral exam, I wasn't rushing. I had my pattern set up. I got through everything with plenty of time left at the end, usually anywhere between 5 minutes left at the end for the singles and sometimes even more for the triples. And that's important to remember. These cases, right, they're not designed to test your medical knowledge. It's those other things I talked about, those other skills. Your written boards are there to test your fine medical knowledge. So these are going to test basic medical management principles, and they're usually for high yield topics, bread and butter EM. They want to know that any physician that passes this test can handle the usual suspects, no matter what EM practice you're going to be going into. And this is why you only need 15 minutes and 30 minutes, and that's more than enough time to finish these cases. The management's not that complicated. You'll usually know right off the chief complaint where you're going with the case, and you'll make the diagnosis really easy. And it's a matter of communicating these other skills, communication skills, organization of data, your resource management. That's what you're going to be getting scored on. So specifically, there's going to be critical actions for each of your cases. About 5 of them to 6 of them for each case. These are predetermined for the examiner to specifically look out for. And it differs for each case, but they're usually 5 or 6 actions that any reasonable physician would have to perform to provide good medical care for this patient. So if you have a patient who comes in with abdominal pain, nausea, vomiting, critical actions might be performing a focused abdominal exam and eliciting McBurney's point tenderness. It might be giving appropriate analgesia and reassessing until the pain is controlled, obtaining a CAT scan, and calling a surgery consult to get the patient to the OR for emergent surgery since the app is ruptured, for example. If you do those critical actions, you will score a certain way on your case. And I'll go over the scoring really quickly. If you miss a critical action, you will be docked points for sure. So it doesn't mean that if you miss a critical action, you automatically fail, or that if you get all the critical actions, you automatically pass. But you want to get all the critical actions because it does pump your score up to a certain level that can't be less than that. And that's the best chance of passing this test. So what do the cases actually entail? It's everything. This is a list from the AVEM website. It's every topic. But even AVEM says there are 4 areas that they like to emphasize the most. The ones that are bold at the start there: cardiovascular disorders, infectious disease, respiratory disorders, and trauma. They also tell you that 50% will be high acuity, right? So critical care, trauma type cases, and there will be pediatric cases sprinkled in between all of these. So if you think about it, you're going to be doing 7 cases. These are 4 areas that they're already telling you they'd like to heavily emphasize. If you're really good at these 4 areas and the critical and you know the pediatric etiologies that go with each of these, that's going to be the majority of what you see that day. And certainly, when I took my test a few years ago, I had all of this exactly as they said. I can still remember some of the exact cases that I had for it. This is just a quick view of what the software looks like. I'm not going to go in depth with it. You guys will have to look yourself and practice with it, especially as time comes. But it's pretty intuitive. You get presented with a patient. You can address the patient, has to examine and find any injuries on it, which get labeled for you. That when you do find any injuries of trauma or any rashes or anything like that. If you put a patient on the monitor, they give you a live rhythm strip and vital signs that can update on the fly when you ask for repeat vitals. When you ask for orders or nursing procedures, the examiner will put up what you ordered and will indicate when it's performed. And as you get back x-ray and other imaging results and lab results, that'll pop up on the button. You can click on it and read it. So it's more in line with what we do in a daily practice. But only the single cases will be like this, and all of the triples will still be on paper. And it's definitely easier to practice on paper and then show up to the test and do the electronic, because this is a little bit easier to do. So by practicing with a book and only with paper, you'll actually be better off when you go and do the real electronic cases on the day of the exam. So scoring, you don't need to know the nitty-gritty about scoring. You just need to do well in these cases, and if you do well in the cases, you'll score well in all of these domains. But these are the domains that they check for. On the left side, these 5 more relate to your delivery of medical care to the patient, right? Did you order the right test to get the right data? Did you use that data to figure out the correct diagnosis? Did you manage all the aspects of the case efficiently and in a good organized manner? Did you utilize appropriate resources? Usually meaning, did you activate or get the correct resources, not overutilization. That's part of it, but it's more, did you underutilize? Did you forget to utilize your social worker or call the primary care doctor to get information? And then how well did the patient do? The other things, though, are how well you communicate with the examiner as they're pretending to be the nurse, the social worker, the security officer, the family member. Did you actually understand what happened in the case, or did you just memorize a pattern really, really well and just go through that algorithm? And then the last one is somewhat subjective. Did you handle it well in real practice? Did you think you could handle the situation as a board certified attending? This is what the electronic score sheet looks like. You can see examples on the left here of whatever case this was, the 5 critical actions that the candidate needed to do. And candidate looks like they got 3 of the critical actions and 2 of them he or she missed. And you can see when the candidate missed this one on the bottom, the antibiotics for patient management, right? That's the domain that was tested for that critical action. The score has been grayed out. And so the most candidate could score was up to a 4 out of 8 on that one. And similarly, when the candidate got, problem solving, this evaluated anemia, and did do that critical action, the lower numbers got grayed out, indicating the candidate should be getting a higher score in that area. And the other ones that maybe didn't have critical actions can be on the entire scale. 7 and 8 means you did incredibly well, you missed nothing. 5 to 6 means you did good, you hit all your critical actions, there were no deficiencies, but maybe you didn't have some extra style points on the way to the case. 3 and 4, you were deficient in at least 1 critical action. 1 to 2 means you did terrible. You really just want to get 5 and up, right? If you hit all your critical actions, take a 5 and up on all these, and you'll probably pass. There is no standardized passing score right now. When I did mine, I was always taught they take the average of your 6 cases, and if it was over 5.75, that was a passing score. Or if you had 1 poor case, they averaged your highest and your poorest case into 1 score, and then just took those 5 scores and averaged them together to get a score. But now the official ABEM website says every year the examiners sit together in a panel, they determine what the score is going to be that year for passing, and I don't know how they determine that. So it doesn't really matter. Just know these are the things that they're going to test you on. You want to hit all your critical actions to make sure you get 5 and 6s at least, not all of them, and you'll probably pass the exam. So how do you actually manage these cases, right? The demo is going to hopefully show that, but these are just some pointers that I want to tell you, as well as what ABEM will tell you. And some of the resources that we have sent out to you are different physicians who also have bullet points and some web docs of other high-yield things to look out for when you're managing this case. And I really just want to convey it's just like managing a real case with just some variation. You're going to be giving an admitted sheet with chief complaint and vital sign when you walk in the room, just like you do when you first pick up the patient off the whiteboard. And then you can go and get your history and physical and do everything that you need. The difference is you have to ask for everything, right? You don't have the benefit of seeing the patient or hearing how they're breathing, so you have to ask for things that maybe you wouldn't normally need to because you're physically there in the room. And you have to be really specific, and that's on your exam too. You can't just say, I want to do an abdominal exam. Maybe the examiner is going to tell you, okay, you did an abdominal exam, it was totally normal, everything was normal. More often than not, though, if you really need that exam, they're going to say, what specifically do you need? And if they're asking you to be specific, it either means that there is an important piece of information they want you to get, and they want to know that you know how to look for it, or it means you're way off track, and you're doing a neuro exam on an epistaxis, and they want to know why are we doing a full neuro exam on a patient with a nosebleed. But be specific and deliberate with what you're asking for, and they'll give you that information. If you ask generally, they might not give it to you because they want to know you understand what you're actually asking for. Now, it differs a little bit too because you have unlimited resources at the fake hospital that you're seeing these patients at. Every consultant should be available. All of the imaging modalities you want will be available. There's no formulary, so if there's any medication you want to give, it doesn't matter if it's there or not. You can order whatever you need to. But not always. Sometimes you're going to ask to do something a certain way, and they're going to say, oh, you want to get an MRI? Oh, the MRI machine is broken right now. Or you have a trauma that comes in. You don't just call the trauma surgeon and talk about the case immediately. They're going to say the trauma surgeon has caught the case upstairs. As soon as they're done with the case, they're going to come and talk to you. That's a sign that they want you to manage the case in a very specific way or in a different way, or in a way that shows that you can handle it without having to ask for help from another service. But ask for what you think is the right way to do it. The examiner will guide you if they need you to answer the case in a very specific manner. You always need to reassess everything you do in an oral board case. If a patient has pain, you give pain meds, you have to make a note to go back and ask, hey, is the pain better? They will always have this on just about every case. If the vital signs are abnormal, you have to go back and repeat the vital signs and see that your intervention helps. So if the blood pressure is low, let me give a liter of fluid. If you don't go back and reassess it, they will dock points for that you didn't reassess to see if your management improved. And more often than not, they'll make it so that unless you reassess the patient, the pain won't be fixed, or the blood pressure won't get better, as a point to remind you that you didn't go back and reassess. So always go back. Anytime you ask for something, you have to make sure that the outcome occurred that you were hoping to get. You don't need to know a ton of things memorized for this in terms of medical knowledge. You do need to know common drugs. I just want to highlight in emergent situations, in critical situations, so drugs from your ACLS and Pal, you should know that off the top of your head anyway, and that makes sense. But if you want to give a medication and you can't remember the exact dose, you can say, I want to give whatever, gabapentin, I don't remember the exact dose for that, I'm going to look up the correct dose. And they'll either say, okay, this is the correct dose of it, or they'll just say, okay, you looked it up and you found the correct dose and you just administered the right dose. So know your common things, know your common antibiotics, your common medications that you would normally need to know when you can't just go and look it up on the computer. In terms of the communication, the examiner is everybody. So the examiner is going to be the patient, the family, EMS, the consultant, the primary care doctor. So depending on how you interact with your examiner, it depends on who the examiner is at that time and how you're going to interact. So if it's with your team and your consultants, you want to use appropriate medical knowledge, right? This is a skill that no matter what practice you're in, whether you have to transfer a patient or talk to your consultant in-house, you have to convey what you are seeing effectively. And just like real life, you might need to stand your ground. You might be talking with a consultant on on a case that you need them to come and see this patient to take to the OR now. But on the oral boards, they're going to say, okay, it's in the middle of the night, I'll come in the morning and see the patient. That happens in real life. They test this on the exam too. They want to know that you are confident in what this patient needs and you can advocate for your patient. And usually, there's not a big fight or anything, like in real life. You could just say, no, this patient's really sick. This is why you need to come in now. And they say, oh, okay, no problem, I'll come in now. So it's good practice for real life. But when you're talking to the examiner as a patient and the family, you need to go back and update the patient. What did I find? This is what I want to admit you. Here's your discharge instructions. And you want to use common language, just like in real life. They want to know you can communicate what you found in a way that will be safe for the patient and the family to understand. So you do have 15 and 30 minutes for these cases. You do have to manage your own time. There's no timer. There's no time warning. But the examiner will give you clues. If I'm just rattling off a million orders quickly and I'm really rushing through, they're going to say, oh, sorry, doc, hold on. What were those orders again? Because they need time to write everything down, and that means you're probably asking for too many things at once. Also, if you're taking a little too much time getting history, they might say, hey, doc, so do you want any labs? Oh, so what do you want to do about that heart rate? They'll give you a mental cue, a verbal cue that mentally you can say, okay, they're trying to scuttle me along in a certain direction. They can't tell you what to do, but many of the examiners will help guide you to make sure you stay on track and on time. And then you need to end the case. It's usually with a disposition, admit, transfer, discharge. Sometimes, usually death is not a great situation in the case. There are some, though, where they might come in, it's a code situation, they want to test your ability to run code, and then test your ability to debrief and update a family afterwards. So patient dying is not always a bad situation, but usually it's going to be an admission, a discharge, or a transfer. That's just some basics on how to manage the case and a little bit about what the eOral boards are. I wanted to do a real quick look into how you should start to think about organizing when you're practicing for the exam. This is something that Sophia sent out from Dr. Tim Lee. This is a pretty simple flowchart. It doesn't go into the nitty-gritty of what you're going to do, but it's a good mental schema of how to approach oral board cases. Almost every flowchart and system that you're going to read or study about will start with a statement like this: as I walk in the room, what do I see, hear, smell? Because you don't have that benefit since you're sitting in a hotel room. And then when you get the idea of sick or not sick, you decide what you do next. Sick, you address your ABCs, you get your IVO2 monitor, you address whatever you find. If they're not sick, you go and get your full history, your full exam, and everything else, and put in your orders like a typical non-critical patient. And if you're unsure, you can ask for some specifics, usually around ABCDs, right, in your primary survey. Now this, though, is a general schema. It's really, what do I see, sick versus not sick, and then interventions if they're sick, followed by history and everything else, or history and then interventions if they're not. So what do you do now, though, if you're trying to practice to figure out, well, what do I do specifically? What are the actual little details I need to get, and all of that? This is an example of a candidate note sheet that you'll be given. It'll just be a blank piece of paper, save for this figure that you can write on if you want to mark down where injuries are, or if you put an IV in, you want to mark that it goes down and where it's located, you can use that. But how can you set this up? This is one way. This is through Foundations of EM. You can actually print these sheets out in the beginning when you're practicing. We also sent this out to you guys. I think we sent this one out to you, right? Yeah. Yeah. And this is great because it has the candidate note sheet on the bottom, which I'll show you in a second, with how they outline to organize their information. But up top, especially in the beginning, you can print this out and bring it to these oral board sessions, right? As a primer and a way to remember what to ask and things that maybe you didn't do. And as you get more comfortable, you can just bring the bottom half of the sheet. And then as you get even more comfortable, you can just bring a blank sheet and fill it out fresh yourself each time. But I think in the beginning, especially if you're not familiar with doing these cases, you should even just print this whole thing out. And look, don't just read it from top to bottom, because that's not helping you do the case, but you'll have it there as something to jog your memory if you're stuck. Oh, did I remember to do this thing or that thing? So that was sent out to you. So look at it, and for the future oral board cases, if you're assigned, usually the seniors, but if you're even in the junior day, consider printing it out and just bringing it with you so you can use it if you're going to practice that with this. And this is the bottom half of that sheet. This is the candidate note sheet now with this 4-box grid and some headers of things to write down information as you ask it. Some people, they walk into the room, they sit down, and they say, okay, give me 30 seconds, and they draw their grid, they draw out whatever they need to, and then after their 15, 20 seconds, they say, okay, examiner, let's start. And that way they can set up everything you need to jog your memory and write down all your information. I did not do this. I actually didn't do any of this. I approached this as if it was a POD or CCT patient. And I asked all the questions in the order that I would normally do on a given clinical day. I would write some things down to help remind myself to go back to things, like if I gave pain meds to reassess, or if I always forgot to get family history, I would just make that note real quick. But I didn't do this big grid myself, but many candidates do. It's really helpful. So I think you should practice doing it full-blown like this, see if there's any errors you constantly miss, and then maybe you can get rid of some of this extraneous stuff that you always ask, and then you don't need to worry about it. So that's a little bit on how to organize. Now we're going to do a case demo. This is a case taken from a case book by Okuda. There's a couple different board review resources out there. This is a book that I use that I really love. It is primarily a case book. There's 100 some odd cases in it. Many of them are written very typical of what you'll see on the oral boards. And it's great to use because non-medical partners can easily test you with it. Maybe not easily, but somewhat easily can test you with it. So you don't need to have a co-resident or another doctor test you. So if you have a significant other who's not in the medical field, like I do, it's easy to follow this outline and go through it. So we wanted to demo a case from this book to give you an example, not only of how it should look on the real day, but give you an idea how you can utilize this resource to do your own studying and practicing.
Okay, so I'm just going to ask you to mute that one. Mute here. And we just have to mute on the computer.
Hey guys, can you hear me? We can't hear anything here. And also stop sharing your screen.
We're just setting up the
I think you can just see me now. Yep. Are you muted? And then we just have to put the PowerPoint slide on the next one. Great. Why they're not seeing this here. Okay, that's okay. We'll get started. All right. So I'll be the examinee. Dr. D will be the examiner.
So this is a 55-year-old man complaining of back pain.
Okay. What do I see when I walk into the room?
You see a man that looks his stated age, who's lying on a stretcher, and he's in mild to moderate pain. He seems to be moving around a little bit. He's not comfortable at all.
May I have a set of vital signs, please?
Sure. Blood pressure is 165/90. Pulse is 90. Respiratory rate is 16. He's afebrile. His O2 sat on room air is 98%.
I'd like to perform a primary survey. Is the patient able to speak to me?
Yes, he can speak in full sentences.
Okay, great. How's his breathing? And how does his skin look?
Okay. His breathing is, he's in no respiratory distress. He's not cyanotic. He is a little bit diaphoretic.
Okay.
And his skin, though, is warm and moist. And he has normal pulses. His capillary refill is 1.5 seconds.
Okay, that's good. So the patient seems stable enough to obtain a further history. So I'd like to ask the patient, sir, what brings you to the ED today?
You know, I was walking to work, and suddenly I got this terrible pain. It started like that in my back. It first was kind of like in my mid to lower back, but it has moved up to my chest and to the back part of my chest and sometimes down to my legs. And it was really bad. Now it's a little bit better, but it's pretty bad. I never had anything like this before.
Okay. Was there a particular position that makes the pain worse or better?
No, nothing seemed to help this.
Okay. Were you exerting yourself? Have you been working out recently? Did you have an injury to that area?
No, I just was going to work like I always do. And boy, you know, it hit me like lightning. I don't remember hurting myself or anything. It was just, you know, out of the blue.
Okay. All right. Are you having any chest pain, trouble breathing, palpitations?
No, I'm just having pain in the back of my chest, but nothing in the front.
Okay. So to the nurse, I'd like this patient to be on a cardiac monitor. I'd like an 18-gauge IV placed in the right AC. And let's just have oxygen at bedside just in case. And we should also get some blood tubes for laboratory testing as well.
Oh, okay, I'm Nurse Duguid. I'll be your nurse today.
Okay.
I can do all of that for you. Okay, he's on a monitor. We have nasal cannula oxygen ready if you want it. And I have the IV in, good IV. And here are your bloods. What do you want me to send the bloods for?
I'd like to first examine the patient and then give you particular orders about the labs.
Sure, whatever you want, doctor.
Okay, so let's
Just make sure you write the orders.
I will. I missed you, but I definitely will. I like to examine the patient and do a head and neck examination.
Sure.
So what do I'm basically looking to see if there's signs of injury, how the pupils are acting, and how the cervical spine is tender or not.
Okay. Before I do that, Ms. Duguid again, do you want another set of vital signs?
Sure, I'll have repeat vitals.
They're the same as they were
Okay.
a couple of minutes ago.
Okay, good.
So when you look at the head, there's no trauma. Pupils are normal. Cranial nerves are intact in the head.
Good.
Neck is normal.
Okay. And I'd now like to examine the chest and abdomen for signs of injury, check a lung exam, cardiac exam, the abdomen for any tenderness or signs of injury or abnormalities.
Okay, chest is clear. There's no tenderness on the chest at all. There is, heart is borderline tachycardic, around 98 now. And there are no murmurs, there are no rubs. And pain is not worse when he took a deep breath when we were listening to his chest. His abdomen is benign, it's soft, it's non-tender, there's no palpable mass.
Okay. I just want to ask you a couple more questions to the patients. Are you a smoker? Do you have any medical problems, any allergy to medication?
I smoke a half a pack a day since I was a kid.
Okay.
And I've never been told to be sick with anything, although sometimes when I went to the doctor, he said my pressure was high sometimes. But I'm on no medicine.
Okay. So I'd like to order some tests. Can I get an EKG, an X-ray, and in terms of the labs, I'd like a CBC, a comprehensive panel, a coag panel, a UA, and a Taitt instrument.
Okay, we can do all of that for you, doctor.
And that's it for me for now. So, are the results back for those labs yet, or no?
Yeah, here's the EKG.
Okay. And how's the patient looking right now?
He looks uncomfortable. He's kind of writhing around a little bit on that stretcher. He's a little bit more diaphoretic.
Okay, so we'll wait for the labs. In terms of the EKG, it looks like normal sinus rhythm, no ischemic changes. Looks pretty good. Can I just get a repeat set of vitals?
Sure. His blood pressure is now 170 over 100. His pulse is 100.
Okay. And how's the patient looking now?
I don't know, doc. You know, he's still complaining of a lot of pain. You know, he really bothers me. I know.
Okay.
You know, I try to do good, but you know.
Okay, yeah, I forgot. I forgot to add some pain medication, so let's give 6 milligrams of IV morphine to the patient now.
Okay, let me ask you, are you allergic? No, you're no allergies.
No allergies.
Okay,
So let's administer 6 milligrams of morphine to the
sure.
patient.
It's done, doctor.
Great. And then let's also.
Did you write that order?
I did, Mr. Good.
Okay.
I made sure I wrote it. Now, I'd like to call cardiology. This patient's looking really uncomfortable. I think there's something going on. I just would like to consult them.
Okay. Well, I have Dr. Rhythm on the phone.
Okay. Hey, Dr. Rhythm. I have this patient here. I'm basically concerned about that he may have something going on with his heart. He's diaphoretic. He's hypertensive, tachycardic. Do you think you could come down and see the patient?
What do you think is going on?
To be honest, I'm not sure yet, but I think it could be a heart attack, it could be a kidney stone, it could be a AAA or a dissection or some trauma, but I think he might be sick.
What does his EKG show? Does it show ST elevations?
It's normal sinus rhythm at the moment.
Okay, that's all?
Yep. I don't have labs yet.
So you don't have anything back yet?
No.
Why are you bothering me? Why don't you get some more tests, and if you find anything, maybe I'll come down.
Okay.
Okay? I'm busy here.
All right.
All right, I have to bill for the EKGs in my.
Okay, thanks. How's the patient looking now? Just would like to know.
His pain is a little better, but his pressure is still 170 over 100. His pulse is 100, and he doesn't look very happy.
Okay. Are the labs back yet?
Yeah, they're all back. CBC is normal. Chemistry is normal. Coags are normal. UA showed no blood and was normal, no white cells. And the lactate is 1.5.
Okay. Can I see the X-ray, please?
Sure. There's the X-ray for you.
Okay, I think I'm going to get a CT scan of the abdomen. I'm maybe a little bit concerned that there may be a kidney stone, an aneurysm, or a dissection. So let's order a CT scan of the abdomen without the contact.
Okay, sure.
Or CT.
I'm sorry, doctor, but the CT scan said that you got to get it protocolized by the radiologist. So they want you to call the radiologist and get it okay first.
Okay, please direct me to call the radiologist.
Hi, I'm Dr. Scan.
Okay, Dr. Scan, I think this patient's really sick. I think he may have a kidney stone or aneurysm or dissection. Can you please protocolize a CT scan so we can get this patient there quickly?
Okay, I can do that. I saw you put in for only an abdomen. You should put in for a chest also with runoff.
Okay, so
In addition, I just have a clinical question. What was his pulses like?
oh, I did not check those. So let's go back and re-examine the patient and recheck all pulses.
Oh, okay. They're normal.
Okay, great. So I'll take your recommendations. Let's get a CT chest, abdomen, pelvis with runoff, so we can rule out aortic pathology.
Okay. It's done. Patient's back from CT.
Okay, let's take a look. Okay. So this looks like an aortic dissection. Do we have an official read on this?
I'll get Dr. Scan for you. He's on the phone.
Okay.
Yeah, it shows a dissection in the descending thoracic aorta going into the abdominal aorta.
Okay.
There's no AAA, and there's certainly no kidney stone. But yeah, he has a type A dissection.
Okay. Type A or type B?
Oh, I'm sorry, it doesn't involve the thoracic. It's
Okay.
type B.
Okay, great. Thank
I'm
you.
sorry. Thank you
That's
for
okay.
correcting me.
That's okay. I think this patient's critical now, so let's move them to the critical area of the ED. Let's
Okay.
start another 18 gauge IV if we can.
Sure, we have one for you.
Great, and let's start them on a nitro drip.
Okay, you mean nitroglycerin or nitroprusside?
We'll do nitroprusside.
Oh, nitroprusside, okay. We have that set up.
Okay. How are the patient's vitals looking now that they're on the drip?
You know, his blood pressure's come down, but his pulse went up. It's 120 now, and he's in more pain, and he's more diaphoretic. Although his blood pressure's down to 110/80, he's complaining more.
Yes, you're right. I realized that we should be controlling the tachycardia as well. Get reflex tachycardia. So let's actually start an esmolol drip as well.
Okay. How do you want to start it?
I don't know the dosing for that, but I'll look it up.
Oh, okay.
The dosing, and then I start.
Okay,
Okay, great.
we can do that for you.
Great. And how's the patient looking now?
His pulse is down to 76. His blood pressure is 110/60. His pain is much, much better.
Good.
He seems a little bit better, still has some pain.
Okay, so let's do this. Let's call a vascular surgery and ICU, and basically run the case by them as well.
Okay, I have Dr. Shunt on the line, the vascular surgeon.
Dr. Shunt. Okay. Hey, Dr. Shunt, I have a patient here who came in for severe back pain, was contacted type B aortic dissection. He got morphine, he's on a nitroprusside and esmolol drip with a normal blood pressure within range and normal tachycardia. So we just wanted you to be aware of this patient.
Oh, sure, you know what? Admit him to the SICU.
Okay.
I will come and see him, and I'll send my fellow down right now, and I'll follow. Continue what you're doing. As long as he's doing better, we don't have to take him to the OR, since he is better and he's not showing any sign of a major pulse occlusion or anything like that. But he should be watched really carefully. Okay.
Okay, great. So I'll admit him to the ICU.
Yeah, I'm sorry to bother you. I'm Nurse Too Good again. But the patient is saying, what is happening?
Oh, wow.
He wants to know if he can go home or what.
Okay, so you're right. I need to update the patient on this. So I'll be talking to the patient right now and letting sir, essentially, we found out that your back pain is secondary to one of the arteries in your abdomen having a dissection, which basically means that it has a little bit of a rupture in the fluid. It's stable right now. We've let the doctors who deal with this know you do have to stay in the critical care unit and get pain and blood pressure control, and they will follow you upstairs.
Oh, okay. Yeah, I'll stay then if you tell me it's that serious. Boy, it's tearing up my artery or something.
Yeah.
Okay, I'll stay.
Okay, great. So the patient's admitted to the ICU, and the patient's aware, and the patient's pain is controlled now,
Right.
and blood pressure and vitals.
Right, and here's Dr. Shunt, and him and his fellow are taking him right to the SICU right now.
Great.
Okay.
All right, that's it. Do you want to debrief the case?
Yes, should we debrief together?
Yep.
All three of us. Dr. Sell, do you want to make any points first, or?
No, we're going to debrief, but right before we go over some of the specifics of the cases, anyone have any comments on what Sophia could have done better or could have done more polished in this case?
Maybe addressing the patient. I don't know if that's what you're supposed to do, but like you weren't like, hey, I'm a doctor, so let's start with it.
Right. So maybe better communication, right? So and at the end, right, she realizes, oh, I'm about to admit this patient in the ICU, and I haven't gone back to actually tell the patient what's going on. So exactly, either addressing in the beginning, hi, this is, I'm your doctor, and also at the end, hey, this is what I found after all the tests, and this is what needs to be done.
Yeah, you get graded on your communication skills, and that's part of it. And if the patient was, let's say, in coma or semi-comatose, then you're obliged to try to reach the family and talk to them and tell them what's happening. So that's important.
Yep.
And we left that out on purpose, actually.
And in terms of the critical actions, those actions that we shouldn't be missing, we'll get doc points for. I'll just review those for everybody.
Yeah.
If that works. So essentially, a neurovascular exam is a critical action. Appropriate analgesia rapidly, a chest X-ray and EKG. Basically, having the patient on a monitor, a CT scan, and a verbalization of your differential. So one of the critical actions is talking out loud what your differential diagnosis is, which I think was why we pushed it with radiology, asking us why we wanted the scans, was basically the examiner pushing us to get that differential out loud. And blood pressure control. So initially we gave nitroprusside drip, which was a blood pressure control, but it didn't control the heart rate too, which is when they had those reassessment of the vital exams, we needed to basically gear towards that. And then the ICU consultation and admission was one of the last critical actions we needed to do.
Along with letting the patient know.
Along with talking to the patient, yeah.
Yeah, and just some of the knowledge that you have to know is how to use your meds. So you always want to, in a dissection, give the beta blocker ahead of lowering the pressure, especially if you're going to use something like nitride that may actually increase the tachycardia because of reflex.
Right, so, and when you hear what those critical actions were for this dissection case, it encompasses a lot of what you would already do or already should do, right, in obtaining the correct history to make it and make the correct differential diagnosis, doing the specific physical exam findings that maybe you're not doing as much in real life, but you should be doing in every patient, so checking for pulses and doing a good neurovascular exam, and then ordering the right tests, managing the right medications, so giving analgesia early and then managing the 2 drips, and then correct disposition. So Sophia got a bunch of those, but we had her miss a couple of those to show. That's how it will look on the actual oral boards. She didn't really address the pain at first, and she said, okay, let me reassess the patient, which you should always be doing on the case, and then the examiner is going to give you a hint. Oh, he's kind of really uncomfortable, really writhing around. She still didn't do anything. Then that's when the examiner said, oh, it seems like he's really uncomfortable. Maybe we should give this patient something. And that'll be the prompt, like, okay, they're giving me a hint, but I didn't address the pain yet, so let me do the pain and go back and see if it got any better.
Okay, when that happens, do they cut points or do they give a prompt or that will still give you
It depends on your examiner. They have some leeway. If she had not when she got the clue, you should reassess. If you don't reassess, they have leeway of screwing you up. For example, you have a comatose patient, and even though it's going to be something else like a bleed in the head, but you didn't do a finger stick, right, and decide whether you're going to get glucose, don't make that patient hypoglycemic on you. They can do that. So what you want to do is reassess, and usually if you reassess, they'll be worse, and then you should think on yourself, hey, what am I missing here? Well, this patient's in more pain, he's more diaphoretic. I should give him something for pain.
Right, so in this particular case, right, the critical action is, early pain medication, right? So it's a little subjective on what is early. So when she got the first reassessment and said, oh, patient's writhing in pain, I think if you give pain medication, they're not going to necessarily dock you points. The fact that she didn't, and there had to be another prompt, they're probably going to say, okay, she missed that critical action, and that's going to be a deficit on whatever of the scoring scales that is.
Yeah, right? They have leeway of how they feel, but if you don't reassess, or if you reassess and still don't get it, then you will definitely lose points.
Yeah, and remember, missing one critical action doesn't mean that you failed the case. And getting all of them doesn't mean that you passed the case, because Sophia could have gotten all these critical actions perfectly, and maybe her communication would be really terrible, or she didn't update the patient, or there's some other aspect that is part of the management that's not one of the critical actions, but it's enough that they're going to dock you enough points that maybe you don't pass that case. And also keep in mind, right? So she probably missed 2, maybe 3 critical actions here, right? So her score is probably going to be docked a good number of points for this. On the exam, if they're still doing it the way they used to, your lowest score will be averaged with your highest score to create one score. So you can do sort of poorly or even fail one of your cases, and it's not an automatic that you're not going to pass your reports. So the idea, though, is not to worry about the specifics, but sort of get an idea of this is what a typical interaction will be, especially if it's not a perfect interaction, right? If it's perfect, it'll all be smooth. There'll be no prompting for anything. It'll just be the candidate directing everything. But frequently you might miss a little something, maybe not in a critical action format, but you'll just miss a question or forget to do a little thing, and you can go back and do it later. The examiner will prompt you, and you'll go back and do it, and you'll do just fine. You'll still get a good score on it, and you'll pass it. Now, the other thing here that you guys will be able to look at with a PDF version of this book that you can all use. I still think the paper one's a little bit easier to use. It's pretty cheap on Amazon. But in addition to reviewing what the critical actions were in each of these cases, they have like a medical knowledge description, so they just go over the pathophysiology of dissections, which you guys all know, but it just highlights certain aspects in case you need to know some medical knowledge about the case, and different pearls about the management of the case. So it's not just, here are the critical actions, what do you do now for practicing this case? You can actually read, what does this particular guide recommend you would do in this case to get maximum points? So this is a great resource for case practicing, which you need to do the most of, right? You just need to do tons of case practicing to get good at this. But if you want more reading lecture style, this book might not be the right book for you, because this is mainly, here's the case, and for this case, these are the pearls that I can give you. I personally think this is the best way to study. That's how I did it. I went through, couldn't go through the whole book, but I went through a good 50 or so cases, and especially the high yield ones. Dissection, this is a high yield case. High acuity, it's cardiovascular, it's one of the main things they like best. If you single out these type of topics, you can really focus your studying as well. Also, it's never too early to study. I did not study for this at all until my 5th year of the MI residency, which was fine, right? But there's no reason you shouldn't be looking at this from time to time, even as a junior, just because this is all about pattern recognition and style. And once you know what the style is, these cases are really easy. The medical diagnosis, right? This is a pretty easy case to make the diagnosis. It's about just doing all the right little things in order. And what I like to say is, for pre-attendings, this is something you can practice too. When a junior is presenting a case to you, right? If the room's not blowing up, you have some time. Have the junior be almost like your examiner, right? For the patient about to present to you. Ask questions, right? Because you haven't seen the patient yet. It's someone else who's reporting data to you. And you can ask questions about what does the patient look like. You can get the history from them instead of having them just tell you the presentation. That's how you can practice even while on shift, this oral board format. And I did do that, and it did help me actually start to get my mind in order.
Yeah, I like this book. It wasn't my favorite before, but the more I used it, the more I like it. It's the EM Oral Boards Illustrated book by Akuda. Very, very good book. And I have to thank Sophia. She really put a lot of work into this, and she put that on file. So you have it for free on file. She sent it off. The other nice thing is that if even after you graduate from here and you pass your written boards and now you want to practice for the oral boards, a lot of people here will practice with you. Dr. Hassel, I will, Bonnie Darren will, Dr. Aquila will. And that's good. The more you practice, the more comfortable that you feel. And one of the problems taking this is getting too nervous. So the more you practice, the less nervous you'll be. I remember when I took mine, I had a trauma case, and I had it was a classical chemothorax. And I knew you put in a large test tube. I had done it. I knew you put in like a 36 or something. And the guy asked, okay, what size chest tube are you going to use? I couldn't remember the size of the chest tube. I was so shaky and nervous, right? And I hadn't practiced very much. So practice makes perfect, and just also calm down. You know this stuff. You've seen these patients. There's no rare case. You know, they're not going to give you probably a pheochromocytoma. They're not going to, you know, give you Takotsubo disease or something. They're going to give you things you've seen before.
And so just remember, we have some of the resources that Sophia sent out. Print out that EM foundation sheet or the candidate sheet, right? Look at it. We'll have a number of these sessions in the future. It won't be a lecture component. It'll just be small groups, mostly with the seniors, but we're going to do one session with the juniors, so the juniors get some practice as well early on. And when those days come up, just you get out of it what you put into it, right? So prepare for it. Volunteer to be the person doing the case. We'll probably do 2 cases during those if we have hour sessions, right? We'll do 2 15-minute single cases and do a triple on one of them. And yeah, you can learn a lot from watching, which is why we did this today, but try to get some practice in some of these sessions. And definitely, if you want more specific private ones, just reach out to any of us, and we're more than happy to do practice cases with you.
Yeah, for someone who hasn't taken oral boards, I think this was helpful, and it does ease your anxiety just reviewing the book. The book has a good intro of like the expectations and even how to practice, and even how to practice with a non-medical person, funnily enough. But I think I'll send out the Akuta book to everybody too after today, so that people have it.
Any questions?
All right, thank you guys.
Thank you, guys.
I think everybody saw it. I saw it from that one.
I mean, that screen. But they heard it going into the chat. So.
Usually. Yeah, so they did see it. Wow, so okay, Zoomers, we're done for the day. Hope that was helpful. Okay, Zoomers, we're done for the day. Hope that was helpful. Please let me know if you have any questions. We're done.